Good evening, all. On behalf of Federation of Family Physicians Association of India, uh, we welcome you once again on this academic feast. This time we are coming with endocrine update, and for that we have got an eminent speaker with us who will be taking us to the journey of this 5 to 6 webinars in the coming months. The topics that we have selected are very pertaining to and very relevant to all the clinicians, may it be physician, may it be family physicians, and practicing anywhere across the world. As FFPAI is committed to upbring the standard of care that family physicians deliver across India to the society, and we are committed and we are shortly coming with the clinical guidelines for managing various diseases that comes into day-to-day office practice of a family physician. So once again, I welcome you all and warm welcome to all, and I hand over the proceedings to Dr. Sanjay Shah, our academic committee vice chairman. Dr. Sanjay, all yours.
Good evening, friends. It is my pride to introduce our today's speaker, Dr. Om Lakhani. Dr. Om Lakhani is consultant diabetologist and endocrinologist, and he is attached with Zydus Hospital, Ahmedabad. He did his DNB endocrinology from Gangaram Hospital, New Delhi, after he completed his MD from MS University, Baroda. He won 4 gold medal in MBBS and 2 gold medal in MD. He also holds specialty certificate in endocrinology and diabetes from Royal College of Physicians, UK. Apart from his academic career, he is master in use of technology. He is a developer of the app Notes in Endocrinology and the website www.endocrinology.co.in. Lots of us have heard him previously also, and today he is going to talk on the topic common errors in the management of thyroid disorder in primary care by giving answers to different frequently asked questions. So, with this introduction, I request Dr. Om Lakhani to talk on the subject.
Thank you so much, Dr. Sanjay Shah, sir, Dr. Barnesh, sir. Thank you for having me for this wonderful session. I'll start by sharing my screen. Is my presentation visible?
Yes, sir.
Yeah, okay. Thank you so much. So once again, thank you for having me for this wonderful session. And I've changed this topic a little bit. I didn't want it to be negative. So the idea is to, instead of saying common errors, and there are, in clinical medicine, there are no errors. There are always differences in opinion. What I'm going to talk about are tips for managing thyroid disorders in primary care practice. We are going to talk about a lot of frequently asked questions and a lot of frequently encountered issues in primary care practice as far as thyroid disorders are concerned. And I'll also give you some tips and tricks which will help you in your clinical practice. So it's going to be packed with a lot of clinical pearls and a lot of practical points. So, yeah. So this is what we are going to start with. So these are the 6 questions that we are going to answer. The first question is, should I order a thyroid function test in fasting or should it be in a post meal? Right? Is an NT-TP or antibody is not coming down? Right? There are times what to do. My patient is having a low TSH. Should I start the patient on carbimazole? My patient's TSH is not coming down. What should I do? My patient has a thyroid nodule or a goiter. Should I get a surgery done? And finally, my patient's TSH is just about normal. Should I treat or not treat? Right? So these are the questions which we are going to discuss in today's practice. Now, in the bottom, if you have any patient with any complicated thyroid disorder, you want to refer it, you can scan the QR code for sending your patient for an online consult with me. Right? So this will be screened at several places during the presentation. So let's start with the first question, right? Should I order a thyroid function test in fasting or can it be ordered at any point of time randomly? Right? So very interesting question. But before we go there, let's step one step back. And let's discuss what test should you order depending on what condition. So it will depend on 2 situations. Either the patient is not having any known thyroid disorder and you are suspecting that the patient is having thyroid disorder. Now, here I would like to say I'm very thankful to a lot of family physicians who actually make the diagnosis of thyroid disorder, right? You are the people who actually make the diagnosis and then refer the patient downstream. And then second is somebody who is already having thyroid disorder, what kind of test you will like to perform. So let's say you don't know what kind of, you're just suspecting that the patient has a thyroid disorder, right? So you're suspecting that the patient has either a hypothyroidism or hyperthyroidism, right? So what test you should do? Now, let's look at it in a way that if your patient is not very affording and you just want to limit the number of tests you want to order, you can just order a TSH, okay? So if you want to order just one test, I would suggest go with TSH. However, if you are suspecting that the patient has hypothyroidism, right, again, TSH is often enough to make a diagnosis. But if you are suspecting that the patient has hyperthyroidism or thyrotoxicosis, in that case, you have to order, it's better to order free T3, free T4 and TSH, right? So this is an important pearl I'd like to give up, right? So if you're thinking that, if your patient has limited resource, just do a TSH. But if you're thinking of hypothyroidism, again, TSH is enough. But if you're thinking of a thyrotoxicosis, at the first go itself, it's better to order all the three, free T3, free T4 and TSH. Now, a lot of you will ask me that what if the patient already has a thyroid disorder, right? Patient is already known case of hypothyroidism or hyperthyroidism or thyrotoxicosis, what test would you order? Now, for a hypothyroid patient, right, on follow-up, again, I would say for limitations of resources, just a TSH is enough. So let's say your patient had a TSH of 15, you started the patient on levothyroxine, and after 2 months, you repeat the TSH and TSH has now come down to 3.5. If your patient has thyrotoxicosis or hyperthyroidism, then a lot of the people make this mistake, and this is a very common error, right? This is a common error. They ask for a TSH on follow-up. No. The test you should do for a patient with thyrotoxicosis or hyperthyroidism on treatment is to check the free T3 and free T4. Here, the TSH often follows the free T3 and free T4. So it's the free T3 and free T4 which gets normalized first, and then the TSH gets normalized. And because of that, a lot of the times I have seen that in clinical practice, I have seen this with a lot of physicians also, that physicians often increase the dose of the carbimazole when the TSH is still low. That is not to be done, right? You have to monitor the thyrotoxicosis with free T3 and free T4, not with TSH, and that is the primary thing you have to keep in mind. So these are the important things, right? So once again, just to say that if your patient is having hypothyroidism, right? So patient has hypothyroidism, then you do a TSH for monitoring. If your patient has hyperthyroidism and you want to monitor, you monitor with free T3 and free T4. Okay, so I think that point is well taken. Then let's go one step ahead. Now, a lot of the time, a lot of physicians often ask me that should you do a free T3, free T4 or should you do a total T3, total T4? Now, it's, ideally, obviously, free T3, free T4 is the better test, but either in most cases is fine. But sometimes the labs are not very reliable. If you have a lab which is not very reliable, which is a little outdated, then it is better to order a total assay because free assays often tend to have more errors, right? So free assay is more difficult to perform and it's more expensive, and that's why sometimes you can have more errors. So that's why if you want, if you are practicing in a rural area, if your lab is not very reliable, it is better to do a total than free. In pregnancy, again, remember the thyroxine binding globulin increases, so your total T3 and total T4 will be higher. That's why if you want to do a test, it's better to do free T3 and free T4 rather than total T3. Again, in liver disease or any other condition where the albumin and globulin levels can be disturbed, free T3 and free T4 are better assays, right? So in general, if again your lab is reliable and if you're if you're in a good lab, if your patient can afford, then free T3, free T4 are the better test. But if your lab is not reliable, then you can go for total T3 and total T4. But in general, it doesn't make too much of a difference except in certain situations like pregnancy or liver disease, etc. Now let's come to this important question, and that is, does the test require fasting? Very interestingly, there are not many papers or not many articles which have actually looked at this, right? And we are proud to say an Indian paper published in 2014 actually looked at this as a question. Does fasting or postprandial state affect the thyroid function test? It's a very simple question, right? Unfortunately, we never had a very good answer. And here is the answer. So this study, what they did was they took patients, they did the same patient's test in the fasting and they did it postprandial, and they wanted to see whether there is a statistically significant difference between the test when done fasting versus postprandial. And from this study, they concluded that the TSH level showed a statistically significant difference when done in fasting or postprandial. That means that there is a difference, especially if your patient, and it can lead to an error, especially if you're dealing with subclinical hypothyroidism. Now, what it's saying is that there is a difference between a fasting and postprandial TSH report. So it is better that you do it in fasting. But let me go into this a little bit deeper. Now, if your patient has subclinical hypothyroidism, or let's say you're doing the test for the first time, it is better to send a fasting TSH, right? So if you are testing for the first time, if you're screening the patient, or if your patient is already having or suspected to have a subclinical hypothyroidism, then send a fasting TSH. But if your patient has an overt hypothyroidism, that means the TSH is very high and T3, T4 are, free T3, T4 are low. In such cases, it doesn't really matter, because if the values are very high, especially more than 20, it doesn't make too much of a difference, right? It doesn't make much of a difference because the difference is actually not major, right? So if let's say, let me put it this way, if your TSH, let's say the difference between fasting and postprandial, generally it is about 0.6 to 1 milli-international unit per liter. This is the difference. It's not a great difference. Okay. So let's take on the higher side. Let's say the difference is about 1, right? So if, for example, you are suspecting, or if you're having a patient with subclinical hypothyroidism, right, the value can range, right, 4.5 to 5.5. Generally, post meal the values are lower. So if you do it in fasting, the patient has subclinical hypothyroidism, but if you do post meal, the patient has normal TSH, right? So sometimes you can miss a diagnosis at this point of time. However, if your patient is having an overt or already high TSH, if the TSH is, let's say, 25, right? So the value can range from 24 to 25, right? So if you do it in fasting, it will be 25. If you do post meal, 24. It doesn't make too much of a difference, right? So the point here that I'm trying to make is that the difference actually is, though statistically significant, not great a difference. Hence, if your patient you're suspecting, or if you're sending it for the first time, send a fasting TSH. But if it's a patient is on a follow-up, especially if you have overt hypothyroidism and patient on follow-up, then in that case, it doesn't really make too much of a difference whether you do it in fasting or post, right? So again, not to confuse you, if you want to remember one, right, this is the answer. But if you want to remember, right, it doesn't make too much of a difference, personally speaking. But when you're doing it for the first time, send it in fasting. Another frequently asked question is, do you send the sample before taking the tablet or after taking the tablet? Right? So let's say patient is on levothyroxine, thyronorm or eltroxin, right? Should you send the test after the patient takes the tablet or before the patient takes the tablet? It's a very interesting question. Now, if you're just doing a TSH, it doesn't matter. It doesn't matter whether the patient has taken the tablet or not. It doesn't really make that much of a difference. But if you're sending a free T3 and free T4 or a total T4, free T4 or total T4, it is very important that the test should be done before taking the medication. Right? This is very important. So this instruction must be given, because sometimes what happens is that, remember, the assay itself, detects if you're taking the levothyroxine, the blood levels of the free T4 goes high, and because of that, sometimes that itself gets detected in the test, right, in the assay. So the assay cannot differentiate whether the thyroid hormone is produced from your body, or it's reached a steady state, or it is recently the tablet is taken from outside, right? That differentiation cannot happen. So it is important that in such situation, if you're doing a free T4, it is better to do the test before the patient takes the medication, and this has to be very important and kept in mind, right? So this is the end of the first question. Just to summarize a few points, important point, right? TSH, if you are doing for the first time, do it in fasting, right? And if you are sending a free T4 or a total T4 along with this, then it is always better that this test has to be done before the patient takes the medication, right? So this is an important thing which has to be kept in mind. Secondly, right, important message over here is that, remember, if you are following up a patient, if you are following up a patient with hypothyroidism, follow up with TSH. If you are following up a patient with hyperthyroidism, do a free T3, free T4 follow up. The third point is free T3, free T4. The assay does not make difference whether it's a total or free, but ideally, if cost is not an issue and your lab is reliable, go for free rather than a total. So these are some important points you have to keep in mind. Now, another common problem that we see in clinical, in fact, when I'm saying this today, just today itself, I got a patient with this kind of situation. A lot of the times we get patients referrals where the patient says that anti-TPO antibody is high, and my anti-TPO antibody is not coming down, and what should I do, right? This is a common thing, right? Now, Let me give you a clinical case scenario. So you have a patient, 47-year-old patient, having subclinical hypothyroidism, right? Just to make it clear for family doctors who are not aware, what is subclinical and what is overt, right? Overt hypothyroidism. So subclinical hypothyroidism is when TSH is mildly elevated, right? Mildly elevated, and TSH is generally between about 5 to somewhere around 10, right? This is generally subclinical. Sometimes it can be up to 20, right? And here the free T3, free T4 are generally normal, right? But what is overt hypothyroidism? Overt hypothyroidism is when the TSH is generally more than 20, right? And the free T3, free T4 is generally low, right? So this is overt hypothyroidism, right? So here we are dealing with a patient with TSH of 8.9, which is subclinical hypo, right? So patient was started on levothyroxine by endocrinologist, and anti-TPO antibody, right, was 1000. Okay, so this is fine. This is a routine case, but after 3 months, the TSH has now come down to normal, right? So again, TSH normal range is about 0.5 to 5, right? So it's now 2.1. It's come to normal, but anti-TPO is still high. A patient is worried, and I am the third endocrinologist which the patient is seeing, right? So patient is worried about what should I do. Okay, so first of all, I forgive my bias here, but let me tell you, anti-TPO antibody is one of the most useless tests in endocrinology. It has very little use, very limited use, and it's a very non-specific antibody. So ideally speaking, in primary care practice, don't send this test. It creates more problems than solutions. In which cases anti-TPO, what is anti-TPO antibody? In which cases is it useful? Basically, it's a marker of thyroid autoimmunity. However, it's a non-specific marker, and even people in general population can have it. And remember, levels of anti-TPO have very little correlation with severity of disease. So if you have high anti-TPO antibody, doesn't mean that disease is more severe, and if you have slightly elevated anti-TPO, doesn't mean that the disease is mild. The levels do not have correlation with severity of the disease. So don't worry about the levels. Okay. When is anti-TPO antibody useful? It is useful in subclinical hypothyroidism, especially like I said, when the TSH is between 5 to 10 and you want to decide whether to treat the patient or not. In such cases, anti-TPO antibody is useful. So if anti-TPO antibody is positive, you treat, otherwise you don't treat. This is a very simple point. I'll tell you the nuances of it in the question number 6, which we are going to discuss. Secondly, if the patient is having pregnancy and hypothyroidism, in that case, anti-TPO antibody is important. Why is important? Because sometimes anti-TPO antibody is correlated with early pregnancy loss or first trimester abortion. So hence, anti-TPO antibody, especially if you're dealing with a hypothyroidism in pregnancy, it's a good test to have. And there is a condition called Hashimoto's encephalopathy, where anti-TPO antibody is found to be high. However, this is a neurological condition. It's not an endocrine condition. It's a neurological condition. But important thing is, even now neurologists feel that this condition is probably overrated. Its existence probably does not exist. Right? It's now known as steroid responsive encephalopathy with autoimmune thyroiditis. The name itself is changed now. So it's not called Hashimoto's encephalopathy anymore. And it's a condition where its existence of the condition itself is questionable. So again, we'll probably discuss that in a separate lecture. But the point is that subclinical hypothyroidism or hypothyroidism in pregnancy are generally the conditions where anti-TPO antibody is indicated. But beyond that, it doesn't have any use. Should you serially measure anti-TPO? Serial meaning, okay, you get it done once and then you on follow-up you get it done. No, never do it. There is no role of serial measurement of anti-TPO antibody. Right? So when the patient says my levels of TSH is coming down but anti-TPO is not coming down, I say don't bother about it, don't get this test repeated, this test has no value. You repeat your TSH, get some other test done, but don't get anti-TPO antibody. So serial value has little value. Right? Now the TSH is normal and anti-TPO is antibody is high. Right? Sometimes somebody, you have all these panels where they do hundreds of tests. In that sometimes somebody does an anti-TPO and anti-TPO is high but TSH is normal. Should we treat this condition? Answer is no. Right? This is generally not treated. There is just, however, one condition where you consider treating that is a lady who is planning for pregnancy or IVF and history of prior recurrent first trimester abortion. This is also a debatable point. However, in this condition, so let's say is a lady with recurrent first trimester abortion and TSH is something like 2.4 with anti-TPO positive. In that case, there is some evidence that you should consider treating. But in general cases, there is no role of treating these patients. Right? You just follow up this patient, but treatment is not required. Okay, now let's look at a condition which is again frequent error in clinical practice, and I've seen this Physicians also make this error very common. Now, generally, we all say, right, the rule of thumb is that if the TSH is high, it is hypothyroidism, and generally it is believed that if the TSH is low, it is hyperthyroidism. However, let me break this myth for you. This is to some extent true, but not always true. Right? Now, always keep this in mind, right, that it is not always true. This generally for an, in general it is true, but for all clinical situations it is not true. It's a very simplistic thinking, right? And when you are in clinical practice, sometimes things may not be as simple. Okay, so again, when you are confused, send it to your endocrinologist. But the point being, what point I'm trying to make is that this is not always that simple. So sometimes what I've seen is that if the clinician sends a TSH, and the TSH is found to be high, they start the patient on levothyroxine. This is fair, right? But if the TSH is low, I also seen that a lot of times physicians start the patient on carbimazole, which is wrong, right? You don't do this. You have to evaluate, right? So again, question here is, my patient is low TSH, should I directly start carbimazole? Answer is no. You don't do that, right? What do you do? There are two important rules. All low TSH is not thyrotoxicosis. In fact, let me tell you, all low TSH is not necessarily hyperthyroidism, right? That is what I'm trying first thing. Secondly, even if it is thyrotoxicosis, it is not necessarily Graves' disease, right? So these are two important rule of thumb you should remember. So let's take a case. So a 50-year-old female comes with history of weight loss, generalized weakness, and has bradycardia, right? Now in thyrotoxicosis, we expect tachycardia, but this patient has bradycardia, has pale listless face, TSH is very low. She has past history of postpartum hemorrhage in the last delivery when she was 35 years old, and after the delivery, patient is amenorrhea. Should you start the patient on carbimazole directly? Absolutely not, because you will treat the wrong condition. You will in fact create disaster for this patient. What is this, right? You have to look further. And that's why I said, whenever you are thinking of hyperthyroidism, always do a complete thyroid function test, free T3, free T4, TSH. So in this case, when the TSH was low, we also sent the free T3 and free T4, and the bradycardia was indicated. Both were low. Let me just put this picture again in a minute. So free T3, free T4 was low. We also sent the cortisol of the patient, right? Morning cortisol, fasting cortisol, which was also low. So what do you think is the diagnosis? So this patient had what is known as Sheehan syndrome. Okay, now let's understand this point a little bit in nuance, right? And this is a very important lesson, which again, a lot of even physicians make this common mistake, right? Now remember, there is this negative feedback system, right? So TSH stimulates, so TSH is produced by the pituitary, right? So TSH acts on the thyroid gland to produce T4 and T3, the thyroid gland, and this T4 is converted to T3. So remember, T4 is a prohormone, and this T3 has a negative feedback on TSH. Okay, so this is the general rule of thumb, right? Now, in general, obviously, right, if the T3 and T4 are less, the TSH goes up. If the T3, T4 are high, the TSH goes down. This is the general. So these are all primary conditions, right? So if you have right, primary hypothyroid, in this condition, the free T3 and free T4 is either normal or low, and TSH is high. This is primary hypothyroidism. Why normal? Because we said there could be subclinical hypothyroidism, right? But there is, and the other way, primary or thyrotoxicosis. In this case, the free T3 and free T4 is generally high and TSH is generally low, right? So this is thyrotoxicosis. But this is primary hyperthyroidism and primary hypothyroidism. But what if there is a secondary condition, right? So secondary. What is secondary? Secondary is when the problem is in the pituitary gland. Okay, so problem lies in the pituitary gland, right? Now either the patient has undergone a pituitary surgery or patient has had in this condition there is a condition called postpartum hemorrhage which leads to less amount of blood reaching the pituitary, which leads to what is known as Sheehan syndrome. Okay, I'm sure you have heard of this condition in your MBBS, right? This is Sheehan syndrome, right? So if let's say the disease is in the pituitary gland, now in that case what happens, right? Let's go back to this picture again. Now the TSH itself is low, right? Okay, so because the TSH is low, the T3 and T4 are also going to be low. Why? Because the T3 and T4, the stimulation is not there enough, right? So when you have a picture, right? Let me put it this way. Okay, so you have free T3, free T4, and TSH, right? Now free T3, free T4 are normal and high. This is subclinical hyperthyroidism. Free T3, free T4 are less, low, and high. This is primary hypothyroidism. If the free T3, free T4 are normal, and this is low, this is primary or subclinical hyperthyroidism. And when this is high, this is low, this is primary hyperthyroidism or thyrotoxicosis. Now you have understood this is a common thing, right? But there is one condition where you have free T3 which is low, free T4 which is low, and TSH also which is low. This is secondary hypothyroidism, right, and not hyperthyroidism. And this is hypothyroidism. Okay, so this happens when you have disease of the pituitary. Now, in some situation, let me not confuse you. Some situation, this TSH can also be normal. In some cases, it could be mildly elevated also. But let me not confuse you. Generally, if you find a patient where the T3 is also low, T4 is also low, and TSH is also low, in that situation, immediately send the patient to endocrinologist because the patient is likely to have a pituitary disorder. Okay, let's look at another case. So this is another 50-year-old female, similar, but let's take some other things, right? Patient comes with history of weight loss, generalized weakness, initially things, but now this patient, another patient has a tachycardia and has an anxious face. Her TSH is again low. She has history of recent viral fever. She has tenderness in the thyroid region. Should you start this patient on carbimazole? Again, no, right? Now, even though this looks like thyrotoxicosis and probably looks like thyrotoxicosis, free T3, free T4 are elevated. So now should you start the patient on carbimazole? No, still not, right? Remember, carbimazole is mainly indicated for Graves' disease. It's a specific form of hyperthyroidism or thyrotoxicosis and some other cause of thyrotoxicosis, but not in all cases of thyrotoxicosis. This is very important. And so before you have a patient with thyrotoxicosis, it is always important to establish the diagnosis. And to establish the diagnosis, if this test is available, you should do a technetium thyroid scan, technetium 99 thyroid scan. And if this thyroid scan shows a reduced uptake, in this, like in this case, you have a condition called as subacute thyroiditis. Right? So subacute thyroiditis is it's not an uncommon condition, it's a very common condition in India. It is generally because of viral infection where you have a transient thyrotoxicosis, right? So typically what happens, and it generally is a self-resolving condition. You have to give a small course of steroids and the thyroid function completely resolves in some time, right? In subclinical, in subacute thyroiditis, generally it is, like I said, because of viral infection. Initially the TSH goes low, then it normalizes, then it goes up, right? Sometimes it can come back to normal or sometimes it can remain high, right? So this is subacute thyroiditis. In subacute thyroiditis, you don't give carbimazole, right? The treatment is not carbimazole. Treatment is to either give glucocorticoids or give nothing and just wait and watch. So remember this here, the important point, and you should not forget this. All low TSH don't start carbimazole directly. All patients with thyrotoxicosis don't start carbimazole directly. Evaluate, find the cause, and if the patient has Graves' disease, where you have increased uptake on a technetium scan, then you give carbimazole, otherwise you don't give, right? And if you are again confused, send it to a nearby endocrinologist. So these are very important lessons we should remember, right? Now, let's take another common clinical situation that we encounter in clinical practice. my patient's TSH is not coming down, what should I do, right? So let me tell you a case here. So this is a case of this is a 28-year-old female who is referred to me for uncontrolled hypothyroidism. And she's a prior history of recurrent first trimester abortion also because of hypothyroidism. Her weight is 65. Her TSH is very high. She has normal T3 and T4, but TSH is more than 100. NT-TPO antibody is positive. I said it's not a very useful. In this case, this NT-TPO has little role, but because there is history of abortion, somebody has given as well. This is fine. It's okay. Currently, the patient is on 175 microgram of levothyroxine every day, which is 2.6 microgram per kg per day. Now, patient says that she is more or less compliant, but she's also taking some other medicines for planning of pregnancy like calcium, iron, folic acid, B12, etc. And she's again planning for pregnancy. So, of course, with TSH of more than 100, you'll say, no, not the right time to go for pregnancy. You have to bring the TSH down. But TSH is not coming down at all. What do you do? So this is a condition which is known as refractory hypothyroidism. Refractory hypothyroidism is when the TSH is high despite for more than 6 weeks, despite the dose of levothyroxine more than 2 microgram per kg per day. So this patient is, the dose is 2.6 microgram per kg per day, that is, it is more than 2, that means this patient is defined as refractory hypothyroidism. It's a very common condition and we get referrals for this very, very often in clinical practice. So what do you do? So these are the 5 steps what you should do for suspected refractory hypothyroidism or patient having refractory hypothyroidism. First is, of course, very important, check compliance. Patient is not taking the medicine at all. Then how will the TSH come down? And sometimes what happens is that the patient takes the medicine just a few days before they come to meet you, right? Because they know that you're going to check the thyroid, right? So in such situations, the T3, T4 often comes normal and TSH is high because TSH takes few weeks for it to come down. So if this, like in this case, you can see the patient says that patient is compliant, but you can see T3, T4 is normal, but TSH is high. So this is a very classical thing. This immediately brings to my point that patient is not compliant, and just a few days before the patient is coming to meet me, the patient has started the medicine. Right? Because of that, T3, T4 is normal, but TSH is still high. Second, very important, the medication has to be given 30 to 60 minutes before breakfast or before any meal. Right? It is very important. However, you will often say that patient says, no, I take it. First thing in the morning. After 1 hour only, I have breakfast. Then you ask them, what about tea? Oh, no, tea I have immediately after taking medicine. Both your tea, coffee, whatever you are having, milk in the morning, that also the gap should be at least 30 minutes, ideally 60 minutes. So sometimes the patient is not taking the medication properly. Sometimes they could have interfering medication. We'll see the list of this. And if despite that you have done all these basic things, most of the time, 90% of the time, it is one of these 3 conditions. And if you have ruled out all of this, then you consider going for what is known as a levothyroxine absorption test and then treat the condition cause of malabsorption, right? So again, 90%, the other 10% you refer to endocrinologist, right? 90% of the time, this is the thing, right? Compliance is very, very, very uncommon. You'll find a lot of patients are not compliant, right? In fact, according to one study, only 275 days of 365 days the patient average takes thyroid medicine, which is very strange, right? That's the reality. There are a lot of other drugs which interfere with the absorption of levothyroxine. This is important, very important for you to know, right? A lot of food products also interfere. We already talked about tea and coffee, but other medicines also can inhibit the absorption. For example, proton pump inhibitors, right? Calcium, very commonly calcium carbonate, citrate, whatever, right? Coffee and tea, right? Beta blockers, tricyclic antidepressants, iron, right? Sucralfate, milk, papaya, all these things, all these medications, all these food items can interfere with the levothyroxine absorption, and this has to be kept in mind, right? So again, remember when you are giving this, ideally you should have 4 hours gap between these medicines, right? Doesn't mean that you don't give iron medicine, you give. Doesn't mean you don't give calcium, give, but keep a gap of at least 4 hours. Right? So typically I say that in the morning you take your thyroid medicine and after lunch you take your iron or take your calcium supplements. Right? So these are important things. Right? So it's very important that levothyroxine absorption has to be kept in mind. Right? And acidic pH is important for levothyroxine absorption. So for example, when you give proton pump inhibitors, that can also impact the levothyroxine absorption. All these food items can commonly impact, and these are all common drugs which we already discussed can impact the levothyroxine absorption. Sometimes it could be some other related factors, uncommon, but not uncommon in India. Sometimes the medicines are fake, storage of the medicine is not correct. Sometimes patients switch to generic medicine, change of brand, etc. It's very important that Endocrine Society, in fact, has a position statement says that in levothyroxine, in hypothyroidism, don't use generic levothyroxine. It's a very important thing which has to be kept in mind. However, it's still a problem. Let's look at the fifth point, the penultimate point. Now, sometimes you have in your practice, you see a patient with a thyroid nodule or goiter, right? So I have a patient with thyroid nodule or goiter. Should I send the patient for surgery? A lot of times I see primary care physicians directly refer the patient to, ENT surgeon or general surgeon or something, right? Remember, I'll question this point, right? Let's take a case. So this is a 25-year-old female who is incidentally found to have a 2-centimeter thyroid nodule on clinical examination. She is asymptomatic, and thyroid function tests are done which suggest normal thyroid function. Okay, so T3, T4, TSH are all normal. What should we do for this? Right? Now, first remember the rule of 10. The rule of 10 for thyroid nodule is only 10% of the population is thyroid nodule. So if there are 100 people listening to this, if I ask all of you to get a ultrasound done, 10 of you will have a nodule. Right? But only 10% of the nodules are malignancy. And only 10% of thyroid nodules require surgery. 90% of thyroid nodules don't need surgery. This is the reality. However, in practice, I often see a lot of the times unindicated patients also undergo surgery. Right? Don't send your patients, first send it to an endocrinologist, let them evaluate and consider whether the patient needs a surgery or not. 90% of the time, patient will not need surgery. Okay, so don't send it directly to the surgeon and send it to a rational surgeon, but don't send it to a person who directly send the patient to surgery. Because 90% of the time they don't need surgery, right? So what is the next step? Whenever you have a thyroid nodule, the important test you have to do, there's one test you have to do, USG guided FNSE, not biopsy, FNSE, right? And based on the FNSE, there is something called Bethesda staging, right? This Bethesda staging is done. Bethesda stage, there are 1 to 6. Only in one, Bethesda 2, right, is benign. Bethesda 3, 4, 5, 6 is malignancy, but most of the cases, 90% of the cases, you will find Bethesda 2. So if patient has Bethesda 2, there is little or no role of surgery, except in very limited cases. Most cases, generally surgery is not required. For Bethesda 3, 4, 5, 6, you can send the patient to a surgeon, it's fine, right? Even in this, some cases it's not required, only 5 and 6 is technically indication for surgery, but fine, I can understand. 3, 4, 5, 6 you can do, right? So the important thing you have to remember is that when you have a thyroid nodule, first do an FNSE and then take a, right? Some other treatment options are also available. So if the patient has a cystic nodule, right? It's a watery cystic nodule, you can do a percutaneous aspiration and ethanol ablation, right? And we do all this in Zydus. So if you have a patient who wants to get rid of the thyroid nodule, but surgery is not indicated, right? We can do other options. Sometimes in solid nodules, especially it's a young female who has the nodule is visible and it doesn't look good in terms of maybe marriage prospect or cosmetic things. In that cases, you can do a USG guided microwave ablation. This is also something we commonly do in our practice. So let's look at another case. 25-year-old female with a large goiter. There is no symptoms per se, but on lying down, this is again very similar to a patient that I saw today. On lying down, the patient has difficulty in breathing and has difficulty especially during exertion. So what should you do next? So if the patient has a goiter, right, even if it's a large goiter, you can, you again have to evaluate, especially if it's nodular goiter, then you should do an FNC. Obviously, thyroid function test has to be done and thyroid scan has to be done, right, especially if TSH is low. These are all basic tests you should do in any goiter before again evaluating. Now, the options are, if the patient has malignancy, definitely send the patient for surgery. But if the patient has a goiter, but it is not malignant and it is euthyroid, then you can consider surgery or you can consider another treatment option which we now do, which is known as thyroid artery embolization. This is something we have started doing in our practice, right? So here you can, I'll show you one case. This patient has a large goiter and patient has been moving around, does not want to get surgery done. So here we did the thyroid artery embolization. So what is done is that the inferior thyroid artery, you embolize it, and you can see the size of the goiter typically you can see reduces, right? So without surgery also you can reduce the size of the goiter, provided of course that it should not be malignancy, right? So you should rule out malignancy. If it's not malignant, you can then go for. Of course, here it's not that visible, but we have now done a lot of patients where we have done embolization and we have had very good results, right? So important message here is that all thyroid nodules and goiter don't directly send to the surgeon. A lot of the times you can have non-surgical treatment options also this should be kept in. Finally, let's look at this condition, which is the most common clinical condition you will encounter in your practice as a primary care physician. You have a patient with mildly elevated TSH. TSH is just slightly high. Okay. So what do you do in that situation? Right. This is what we are going to discuss in the next slides. Right. So you have this patient, a 42-year-old female, obese, BMI is 32, her TSH is 5.2. She is pre-diabetic, LDL is high, SGPT is high, USG shows fatty liver. Should you treat this patient or not treat this patient? Right. This is the question. Okay. So what is this? This is known as subclinical hypothyroidism. We already discussed what is subclinical, what is overt hypothyroidism. Subclinical hypothyroidism is when mildly elevated TSH and T3, T4 are normal. And overt hypothyroidism is when your TSH, which is very high, more than 20, and the free T3, free T4 is less. So first thing you have to remember that obesity itself leads to mild increase in TSH. So those people who are obese will have a slightly high TSH. It's a very common thing and it's a common rule of thumb. So because obesity increases a hormone called leptin, and this leptin increases the TRH, which is from hypothalamus, which increases the TSH, right? So obesity itself leads to slightly elevated TSH. So when you have mildly elevated TSH, like in this case, obesity itself may be there, right? So this is the conventional algorithm which you can see here. So I'll discuss this. When you have a subclinical hypothyroidism, right? This is subclinical. Let's say if the patient is female and planning for fertility or pregnancy, then it's a separate issue, right? We'll discuss that in maybe a separate talk. But in other cases, right, it's a general case where pregnancy is not an issue and other things are not there, right? If it's more than 10, TSH is more than 10, definitely treat the patient, right? Now, if a TSH is between 7 to 10, then look at the age of the patient. Young patient, less than 70, you treat. More than 70, only selected cases you will consider. The TSH is between 5 to 7, okay? Again, look at age of the patient. If the patient age is more than 70, no treatment, just follow up. It's less than 70, then this is where you look at the anti-TPO antibody, see if the patient has goiters, see if the patient has chronic kidney disease, see if the patient has high CV risk, and if there's any of this condition, then you treat, otherwise no. Okay, so this is the flowchart and algorithm for management of subclinical hypothyroidism. But actually, I myself as an endocrinologist am challenging this point. In fact, if you have seen, this recent, there is a new drug called resmetirom, right, which is the first drug which has got approval for non-alcoholic fatty liver disease. This is actually a thyroid hormone analog. It's a T3 analog. So what now new studies and new evidence has shown that in liver, right, if especially you have fatty liver, using thyroid hormone or T3 or analogs of T3 is very useful in reducing the progression of the liver disease and progressing to fibrosis. So my rule of thumb is that if you have a patient with subclinical hypothyroidism and patient has NASH or NAFLD or non-alcoholic fatty liver disease, if TSH is more than 10, definitely you treat. We have seen this in the other case also. If it's between 4.2 to 10, that is if it is between that, right? If the patient has diabetes and NASH NAFLD, you should treat. The patient has dyslipidemia and NASH NAFLD, and you can treat. If not, you can observe. But the point is that generally, if the patient has subclinical hypothyroidism and NASH, probably it is a good idea to consider treatment in this situation, because we already shown with one drug that actually it can prevent the progression of liver disease. So this is a modern thinking, right? After the advent of this new era where you are looking at resmetirom as a potential. Just to find, if there's an interesting patient you want to send or if you want to discuss, right? You can send for an online consultation, right? And for anybody who is interested in endocrinology in general, this is our WhatsApp channel. All the notes in endocrinology, we used to have an app called Notes in Endocrinology app, but unfortunately for temporarily we have discontinued the app. All these notes are available on our website endocrinology.co.in, right? These are available. But if you want regular updates and some interesting things in endocrinology, this is the QR code for our WhatsApp channel. You can follow us on this WhatsApp channel and you will be getting a lot of interesting content on regular basis. This is the Twitter, right? This is my Twitter handle. This is the same photo which I still have there, so you can follow me there, right? We have written 2 books in endocrinology. These are very question and answer format book, very easy to read. Right? Both of them are available on Amazon and and the other books like Flipkart and other things. So they are available. It's called The Best of Notes in Endocrinology. There are 2 volumes. First volume is general endocrinology. Second volume is for diabetes. So you can have a look at these. right? So thank you for the patient listening, and once again, thank you for having me for this.
Thank you very much, Dr. Om Lakhani. You have covered the topic very nicely. But we have certain questions in YouTube, those who are viewing on YouTube.
Sure,
First
sir.
question is by Dr. Abhay Burgaonkar. He asked a question that in routine test with no symptoms, if one gets TSH more than 100, how to go ahead? I think that you have taken, but you can give the answer in short.
Yeah. So if you find in a routine case, even if the patient is asymptomatic and TSH is more than 100, definitely there is indication to treat. Directly start the patient on treatment. What dose to give? Generally, now current recommendation is that you can directly start with full therapeutic dose. That is 1.6 to 1.7 microgram per kg. That's the therapeutic dose which you can give. But if the patient is elderly or has a cardiac disease, in such cases you can start with a low dose like 25 microgram, and then you can gradually increase the dose based on the TSH, and you should try to target the TSH to a level less than 5, right? That's an ideal. In against certain cases less than 2.5, right? But the point is, if you find even if the patient is asymptomatic, TSH is more than 100, definitely consider treatment.
Another question by Dr. Hari Dayana. He asked question that euthyroid solitary nodule in right lobe more than 2.5 centimeter in size. How to manage?
Yeah. So like I said, first of all, the first step is to get an ultrasound, and with the ultrasound, get a USG guided FNSE. Right? So get an FNSE done. In FNSE, like I said, there are 6 grades of Bethesda: 1, 2, 3, 4, 5, 6. Grade 1 Bethesda means that the test has to be repeated, so sample is not enough. Grade 2 means B9. So if you have Bethesda 2 and 2.5 centimeter nodule asymptomatic, don't do anything. You can just follow up the patient. If the patient has cosmetic concern, then you can offer the patient a thyroid artery and thyroid micro radiofrequency ablation or microwave ablation. If it's anything more than Bethesda 3, 4, 5, 6, then send the patient for surgery. And surgery, especially if grade 5 and 6, it is likely to be malignancy, then go for total thyroidectomy. And 3 and 4, you can consider depending on, you can consider hemithyroidectomy, or depending on the clinical situation, maybe even total thyroidectomy. Right? So the idea, the first step you have to remember is that first step, a lot of people get thyroid scan done, technician. No. Thyroid scan is only required if TSH is low. Right? If the patient has euthyroid, TSH is normal, then the first step is to do USG guided FNSE.
Now, my question is nowadays thyroid tablets are available in different strains.
Yes.
So, whenever we start any dose, and at what interval we should repeat, whenever we change the dose, at what interval we should repeat, and if the TSH value is coming to normal, then at what interval we should advise to repeat the test.
Yeah, very good question, sir. This is a very good question. So if you have a patient whom you have started the patient on thyroid medicines, then generally you repeat the TSH at about 2 to 3 months interval, right? So you start don't do that before that, because sometimes what happens is that for the TSH to actually stabilize, it has a long half-life. The TSH to stabilize, it generally takes about 6 weeks. So on an average, you have to give at least 2 months time for the TSH to stabilize. So whenever you change the dose of the thyroid medicine, it's always a good idea to repeat the TSH after 2 months. Unless, of course, there is some urgency, maybe surgery, something like that. It's a different issue, but most cases we repeat at 2 months, right? And if the patient has a stable thyroid dose, right? So let's say patient is on 100 microgram for many years, and the TSH remains normal all the time. Then in that case, you can repeat at 6 months or even annually also, right? So once every 6 months, if patient is compliant, the TSH remains normal, then you can repeat the test at 6 months. But if the patient if you are actively titrating the dose, then generally we repeat at 2 months.
Nowadays, the tablets are coming in 120 tablets form.
Yeah.
Now, if we do the test after 2 months, then patient will have the same tablets, and if we want to change the dose, then it will be little bit difficult. Do you advise to take the tablets in half dose?
Yeah, it can be done. You can it's scoreable tablets, so you can do half dose also. So if the patient is on 50, you can make it 25. Other trick of trade, what you can do is, remember, it's again, levothyroxine also has a long half-life. It has a half-life of about 7 days. So you would have seen a lot of endocrinologists also, and a lot of other people also do it in such a way that you take this tablet for 5 days. Don't take it on Saturday, Sunday. Or you take 50 microgram on Friday, Monday to Friday, and Saturday, Sunday you take 75. You can do all these titrations also, that is also possible. So what you very rightly said is actually a very common issue in clinical practice, that patient then says, I have to get another new bottle because I have still tablets remaining, right? So in such situation, it's not very expensive tablet, but at the same time, patient is also concerned, right? Okay, why waste? So in such situations, sometimes we do a middle of the ground. So we say that just requires a mild titration. Let's say the TSH is 5.2, 5.6, right? Slightly high. I just want to slightly increase. I say that Monday to Friday you continue 50, Saturday Sunday you take 75, right? So you buy either a 75 tablet or you are taking 50, buy a 25 tablet, take 50 plus 20, right? So this kind of iterations you can do, right? And patient generally agrees to that. So that's generally not a problem, right? So I had this one patient who said, okay, I would just, for thyroid I will come to consult you only. But that patient who lives in US, the patient realized that, this guy changes the dose of the medicine. How am I going to get all the medicines all the time from India? So he said, what I'll do is, I'll take 25 microgram tablets only. Whenever I go, I take 25 microgram only. But he thought, whatever dose you do, right, I adjust with the 25 microgram, right? So that is also possible, and patient is now, whatever dose he's taking, he's maintaining with that level, right? So it happens. So that is possible. It's like a building block. He said, I'll take 4 25 microgram tablets, right? If you say 100. So it's some people have their ways, but yeah.
It's a good solution you gave. My another question is in old age, particularly above 70 years, you advise that you should not treat subclinical hypothyroidism. But in certain cases, like a patient is having very lethargic or depressed feeling, could it be because of hypothyroid and we should give some mild dose of uh,
Yeah.
thyroid medicine?
Oh, it's possible, sir. Generally speaking, more than 70, what happens is as the age advances, the TSH value, both the ends, it actually expands, right? So something, at age about 70, about TSH about 6, up to 6.5 is often normal also, right? And what some studies have shown is that giving this patient levothyroxine generally does not help. But if the patient, if you feel is symptomatic, right? If the patient is symptomatic, patient is having fatigue, lethargy, maybe, there is no harm in actually giving, but give a low dose, because some of these patients could have an underlying cardiac disease which can sometimes be precipitated if you give it very aggressively, right? So it's very important that in older patients, especially who are risk of arrhythmia or risk of cardiac disease, in such cases, if you're just treating it from symptomatic point of view, start with a low dose and see how it goes. So yes, selected cases you definitely can consider treatment. It's not that you don't treat at all. Generally, some selected cases we also treat, right? Depending, you feel that the patient has some maybe would get benefit, would consider treatment. But having said that, you have to be a little careful in that age too, because of if you very aggressively treat, then you might actually create problem.
Another question is in pregnancy, the TSH levels, we know that it should be a little bit lower than the normal level. So, in pregnancy, suppose we start any dose, at what interval we should repeat that
Yeah.
TSH?
Yes, agreed. So just like we discussed that, in a general situation, we generally repeat at 2 months or 3 months interval. In pregnancy, initially it is in the first 18 weeks, we repeat at a monthly interval. Even though, like I said, it still takes, even in pregnancy, it takes a little time, but in pregnancy, because of the, changes in the volume and distribution of the medication, sometimes the stability takes lesser time. So, in pregnancy, especially in the first 18 weeks, we generally repeat at 1 month or 6 weeks, right? But after 18, why 18 weeks? Because after 18 weeks, the fetus also starts producing its own thyroid, right? So when you're treating during hypothyroidism in pregnancy, you're treating the mother as well as the fetus, and the fetus is very important to treat because the fetus does not have its own thyroid hormone production up till 18 weeks, and the neurological development of the fetus is dependent on the mother's thyroid hormone. So that's why that initial 18 weeks is very, very important, very crucial. So you have to have a tight titration, right? Of course, don't over-treat it, but don't under-treat it also, because it's very important that you give correct treatment, right? So in that situation, we repeat at monthly interval up till 18 weeks. After 18 weeks, if the patient is having normal TSH, then I repeat at 2 months or, depending on, whatever the clinical situation. But generally, up till 18 weeks, be a little more, frequent in terms of follow-up.
Most of the time after delivery, we are again rechecking a patient is hypothyroid or not.
Yeah.
So in how much percentage of patient you see that hypothyroidism continue after delivery also?
Yeah. So if the patient had a very high TSH right at the beginning, for example, TSH more than 10 or more than 15, that patients will require treatment even after pregnancy also, right? But if the patient had a mildly increased TSH, like 6.2, 5.6, you're given a very small dose, in such cases, sometimes the TSH is normal after delivery, and then in that case, you can discontinue the medication. Again, in patients who have NT-TPO, this is where NT-TPO is useful. So patients with even mild TSH of 6.2, 6.3, but NT-TPO is positive, those patients will generally continue the treatment after the delivery also. So it depends on the clinical situation, but generally higher TSH, the patients will require treatment even after delivery. Mildly elevated TSH, NT-TPO negative, you can probably give a trial of discontinuation of the therapy and see. But if mildly elevated TSH and NT-TPO is positive, I generally again continue low dose of levothyroxine. And you can in fact develop a new onset hypothyroidism after delivery. It's called postpartum thyroiditis. So typically at about a few months after delivery, the patients can develop a new onset of hypothyroidism. So that is sometimes, and that in fact a very important cause of postpartum depression is thought to be postpartum thyroiditis. So it gets missed, doesn't get diagnosed. Patient has labeled as a postpartum depression, and then somebody does a TSH. TSH is very high, 100, 200. So sometimes that can be missed out. So again, if you have a patient where you're suspecting a postpartum depression, weight gain, etc., do a thyroid function, because you can develop a new onset hypothyroidism after delivery also.
Not only postpartum depression, I think each and every depressive patient, once they have to be tested for TSH.
Yeah.
I think there are lots of questions in YouTube. Dr. Pragnesh, you have seen these questions?
Yeah, there are a lot of questions, but because want of time, I will ask 3 last questions and then we'll stop.
Sure.
A quick word on thyroid supplements. There are vitamin tablets available, and we have seen the result. That patient is not having TSH control. We give it, rather than increasing the dose of thyroxine, we give it and then the TSH comes normal.
Yeah, so the only supplement worth some consideration, I would believe, is actually selenium, because it is part of the enzymes which are there in the thyroid gland. Selenium does have a role. In fact, a lot of studies have shown that in fact, not only that, it has role in thyroid associated orbitopathy, also Graves' orbitopathy. So there is some role of selenium supplementation. Again, the correct dose, we have never been able to kind of establish what is the right dose, whether we are giving a low dose and it's not adequate. So selenium supplementation has some role. As far as the other supplements are concerned, generally no. Right? Generally, we do not advise. It doesn't have any evidence to back it. I have also seen a lot of people give iodine supplementation, which is sometimes could be very dangerous, because sometimes what happens is in a patient with a low iodine state, if you give it, sometimes you can trigger an autoimmune phenomenon. So be very careful. Don't give iodine supplementation. Sometimes we have seen this happen because in India, if you see these multivitamins generally don't contain iodine, but multivitamins from outside, from the US, you have all these big bottles. They often have iodine content. So sometimes you have triggering of the autoimmune disease also, right? So be careful of supplements. I'm generally okay with selenium supplementation. These are generally helpful. The other ones, iffy evidence. And generally, if the patient has very high TSH, these things are not going to matter too much. Mildly elevated TSH and subclinical hypothyroid maybe. Sometimes, again, there is a school of thought that this probably it's getting corrected on its own, and we are probably complementing the supplement, but that could also be a possibility. But only supplement I think probably worth consideration is selenium. The other ones probably not.
One controversial question about the other pathies talk about role of diet in hypothyroidism. They give such diet and the thyroid goes.
Okay, so I'll tell you how it works. If it works, see, if again TSH is very high, 10, 15, 20, it's not going to work. If the TSH is mildly elevated, about 5.3, 5.8, I told you that obese people have higher TSH because of dieting. So even if you have mildly elevated TSH, 5.1, whatever, whether treating, not treating, but if you have 5.1 TSH, if the patient loses 10 kg weight, 15 kg weight, TSH will come down on its own, right? So that is something which is, so all this diet, right? I tell the patient that, there's no specific diet. If you just lose your weight, the TSH is going to come down, right? And sometimes people think the other way, that my TSH is high, that's why I'm not losing weight. That is true again if the TSH is very high. Mildly elevated TSH is the other way around, right? In fact, it is because you are overweight, the TSH is high. So again, it's a little bit, situation where you have to explain to the patient, right? But generally, if the patient is having 5.1, there is no other indication for treatment, and doesn't look, let's try to focus on weight loss, and your TSH, this 5.1 will be dragged down to normal, right? Then whatever diet you want to try, it's fine. But when your TSH is 10, 20, 30, no diet is going to work.
Okay. Dr. Sanjay, I think let's conclude. There are questions coming, but I think it is more than an hour. Let's conclude. You can go ahead.
Anyone have a question, they can ask Dr. Om Lakhani directly also. So we are thankful to you, Dr. Lakhani,
Yes, sir.
and we will continue to have in next session also. Thank you very much, sir.
Thank you. Thank you so much.
Thank you.
Thank you. Good night, sir.
I conclude.